The co-administration of alpha blockers with antimuscarinics is now a recommended treatment option for patients with BP who suffer also storage LATs. We would have thought that the antimuscarinics act via the bladder. However, we know that all 5 muscarinic receptors subtypes have been identified in the prostate as well. The role in BP or AB is yet to be identified. We try to find whether there is an effect of antimuscarinics also on the prostate in parallel with the bladder, and we conducted a small pilot study in a randomized fashion with patients with BP or AB symptoms, were randomized to receive either tamsulosin OCAS or a combination of tamsulosin OCAS plus solifenacin 5 milligrams, which could be titrated to 10 milligrams after 1 month of treatment. And the study's duration was up to 24 weeks to 6 months. We followed a number of parameters, bladder diary questionnaires, the IPSS or ABQ questionnaires, urodynamic studies, and these are the results. We had 31 patients in the tamsulosin OCAS group and 32 patients in the combined therapy group. The baseline demographics and scores were comparable between the 2 groups of patients, and clinical results were more or less what was expected. There were significant changes in bladder diary parameters, which were a bit better in the combination study group. Again, the results from the questionnaires were more or less expected. The IPSS storage score was more improved in the combination group, where the voiding score was more improved in the tamsulosin OCAS group, and the OABQ score was again more improved in the combination group. The results from the ultrasonography, which were the primary endpoint, the changes in the total prostate volume, adenoma volume, and the detective vessel surface were the more interesting ones. And so there was a significant difference, as you can see, between the 2 groups. In the alpha blocker group, there was an increase in prostate volume as opposed to a decrease in the combination group. Similar results for the adenoma volume group, and similar and even more appreciable results in the detective vessel surface group. Again, these were the non-invasive urodynamic results. There was better improvement in the alpha blocker group. The post-PVR again improved in the alpha blocker group, but not in the combination group. And again, the mean voided volume improved in both groups, a little bit in the combination group. So in conclusion, results of this pilot study suggest that a combination of solifenacin with TOCAS affect morphometric properties of the human prostate, with a decrease in total prostate and adenoma volumes, as well as vascularity, contrary to the effect of tamsulosin monotherapy. The results need to be confirmed in larger studies probably, while mechanistic studies could clarify whether these reflect a molecular effect of antimuscarinics on the prostate in parallel with their expected bladder effect. Thank you.
Thank you very much. I have one question. So did you check the testosterone before and after? Testosterone, serum testosterone?
Yes.
What's the change before and after?
I do not remember the results, to be honest. It's part of the thesis of one of my research fellows, but there were no, I can't remember whether there was a significant effect on testosterone.
Okay. Please.
Kai Tikkinen from Finland. Thank you. Very, very interesting work. Congratulations.
Thank you.
2 methodological questions. First, did you have a matching placebo? Did you have a matching placebo?
Placebo drug, no.
And 2, was the truss person who did the truss, was he or she blinded?
It was done by two fellows.
Did they know in which group the person is having the drug or not?
Yes, they did.
Okay. So this is a little bit risking the
bias,
but interesting work. Thank you.
Thank you.
Dr. Jeanette Potts from California. for the sake of our colleagues who may not have ultrasonography in the office, and we're looking at the clinical follow-up of patients, for at least a decade, people have been very frightened about giving an antimuscarinic in the setting of BPE. So I'm wondering, you showed a correlation with the diaries and the ultrasound, but did you actually find, looking at individual patients, a correlation between their fluid diaries and their PVR ultrasound?
How is that going to affect results?
Well, I'm just wondering about, when clinicians prescribe the combination therapy and they follow the patient afterwards, if they could feel confident seeing in the individual patient an improvement in the fluid diary results and be confident that they don't need the PVR ultrasound. You would assume that if there is no problem with the combination therapy, the patient would have a greater bladder capacity and the 24-hour urine volume would remain stable in the pre-treatment group. Therefore, you could be very confident that the person is not going into a silent retention on the combination therapy. So I'm just saying, is there a correlation between the patient's fluid diary and the ultrasound result in each patient?
Yes. Okay. No, we didn't check for a correlation between the fluid diagram and fluid intake, I guess. That's what you mean. Or do you mean the urine voided volumes?
Yes. I mean, if you have a fluid diary and
Yeah.
you do this in your practice regularly...
What do you call a fluid diary? Do you talk about fluid intake, or do you mean voided volumes?
I don't think it's important for such kind of silent retention. I think most of the patient important is acute retention. And so you'd already checked
we didn't have any acute retention cases. We did have 3 cases who had increased PVR. The study criteria originally were designed following earlier studies of combination of alpha blocker with an antimuscarinic. So we had a PVR cutoff of 100 mils to enter the study. There were 3 patients who were actually at the end of the study taken out of the solifenacin 10 milligram group because they had increased PVRs of 170, 280 mils, and the other one 140. But they started with 30, 50, and 100 mils respectively.
Okay. All I'm asking is, the GP who prescribes combination therapy need not fear placing that patient into retention, provided that the fluid diary, the output, shows improvement.
Thank you. Thank you very much. I think it's very interesting study. So you should need we need some kind of a pathophysiology, the mechanism of the change of the prostate.
We have taken biopsies from the patients who underwent prostatectomy, and this is part of another study which I'm going to present in the e-poster section.
Thank you. So it's time. Sorry, next.